Hello, we are excited to be here today to talk about STI awareness, what every physician should know. I'm Linda Eckert. I'm an OBGYN with an infectious disease background and have worked at Harborview Hospital at University of Washington, including in the STI clinic for over 3 decades. And I'm very thrilled to be here with Anna. Anna, why don't you introduce yourself?
Sure. Hi, everybody. My name is Anna Powell. I'm a general OBGYN, also with an infectious disease background. I do research in the space and am co-director of our HIV women's program at Johns Hopkins, where I've been since 2017. So very excited to be here with you today.
So, Dr. Powell and I will be talking about several aspects of STIs, but our main goals of this session are to talk about approach to our patients and how we're going to diagnose and treat STIs, as well as messaging, and then really testing and some latest, greatest updates on what are key messages that are changing or key treatments that are changing. So we're really thankful for the opportunity to talk about this. We know that STIs are increasing. We know how we message about them is incredibly important. And we think that accurate information is really empowering. One of the key things we're going to talk about as we go through all of these STIs is the power of stigma and how stigma really impacts care, impacts patients in accessing care, and it certainly also impacts physicians. And so it's really important for us to be aware of our own biases and be assured that we're not messaging with a way that contains those biases or creates any stigma for the patient.
Our next key message is for folks to keep in mind that a lot of times sexually transmitted infections may be completely asymptomatic. And so being aware of that and making sure we're following CDC guidelines for routine screening for folks age 15 to 24, or that for anybody who has, new sexual partner or multiple sexual partners, that we're talking to our patients about testing and making sure that we ourselves are aware of those guidelines. We also want to make sure that as providers that we're taking a good sexual history, using non-judgmental, non-stigmatizing language to create that rapport, trust with your patient so that we can get accurate information from them and help them make important choices for their own health.
Yeah, and I think it's really important for us to think about as providers how we can use the least judgmental information possible, or how we ask questions to try to use words that don't assume gender of the partner or gender of the patient, to be essentially as I guess, objective as possible as we go through talking about STIs. And so, with that as a background, why don't we move into talking about really, what is an STI and do we have any new kids on the block?
Yes. So a sexually transmitted infection is basically any, bacterial, viral, parasitic infection that one gets diagnosed with as a result of a active intercourse of some kind, and that could be oral, vaginal, anal sex. So we'll be talking about those, most common types of bacterial, viral, and parasitic infections. One very recent, I think, big change in our field here is that very recently, as of I think last week, bacterial vaginosis is we've now gathered enough information to be able to support the thought that BV is sexually transmitted. I'll say this is not a new idea. It's actually, people have been talking about it for many, many years now, but there's always been some evidence to the contrary. And while we don't maybe think of it as a traditional STI, it certainly, there is now enough evidence to say that it is sexually transmitted, and we'll go through that in a little more detail shortly. Additionally, in the last maybe couple years now, there's been emerging information about the use of post-exposure prophylaxis using doxycycline as a way of, so using treatment as prevention for gonorrhea, chlamydia, and technically syphilis. And this has primarily been shown among men who have sex with men and transgender women. But we'll also talk about that in a little bit more detail and how that, if that applies to cisgender women or not. That was it, right? Yeah.
Yeah, we have been definitely using the idea of treatment as prevention for HIV, but moving it into the more common bacterial STIs such as gonorrhea and chlamydia is a new thing. So we're going to talk about that a little bit. And the other thing that we're going to talk about is the testing with now a broader acceptance of using nucleic acid testing. Both of us love our microscopes, and we realize that microscopes can give a lot of very good information to do a basic wet mount and assess for various types of vaginal infections, including STIs such as trichomonas. But we also recognize that many people don't have a microscope available simply because of CLIA recommendations, and that it is something that takes a lot of practice and familiarity. And so in that regard, I think it is important to realize that nucleic acid testing can be a really good way to move forward and is quite accurate. So we'll talk about that.
Yeah.
One thing I often get asked by my patients is, can I catch an STI sitting on a toilet seat? And so I do think that fomite transfer, which is the official name for that question, can occur with sex toys. It's been documented with trichomoniasis, also with bacterial vaginosis. And we know that human papillomavirus can be transferred by finger contact. It doesn't require insertional contact. Insertion is much more efficient, but finger contact is sufficient to transfer HPV. We don't think of the bacterial STIs of gonorrhea and chlamydia being able to be transferred by fomites. We don't think of HIV as transferred by fomites. We think of that as body secretions. But, if people do ask, what can I get off a toilet seat? It's not so much the toilet seat, it's more of the sex toys and direct digital contact.
Yeah. And that's not, I mean, this is not new information, but it is a frequently asked thing that we, like to make a public service announcement about.
Yeah, exactly.
Perfect.
So
So
why don't we move on to talking about some of the more common bacterial STIs?
absolutely. So just a quick note about bacterial infections. So generally these are, infections that are curable with antibiotics, at least for now. And one important point to remember is that there is a higher likelihood of transmission, from penile to vaginal exposure. We also want to remember or keep in mind that these can be multi-site infections, or you can have multi-site exposures. So, not just vaginal, but anal or rectal, oral, and ocular even. So the treatment recommendations take these into account. And for the most part, the treatments are the same depending on the location of exposure. But if you're not sure, just double check CDC guidance for that. Don't be afraid to test multiple sites because, potentially if you don't ask, then you may not catch a non-vaginal site infection. And then just keep in mind that potentially treatment options could change a little bit. It's also important to remember that STIs can be acquired without penile insertion, as we just mentioned. So potentially, if somebody's using sex toys or other paraphernalia, then we want to be careful and ask about those types of exposures as well. So we can start off with chlamydia, which is an intracellular bacterial pathogen. It's probably the most common bacterial infection that's reportable in the US. Interestingly, it causes actually a wide variety of diseases. The one we'll focus on mostly for our discussion today is the chlamydia that causes a genital infection, but there's also chlamydia that causes trachoma. So there's different serovars of chlamydia, and one type causes trachoma, which is an eye infection that results in blindness and is very common in underserved areas. Lymphogranuloma venereum is another infection that is not super common outside of men who have sex with men. And then we, just a point that we apply antibiotic ointment to infants, newborns, in order to prevent ocular infections for newborns as well. Chlamydia can be transmitted by, any of the sexual routes we mentioned, so vaginal, oral, anal, or perinatally again. And it can affect any age, but probably most commonly diagnosed in the 15 to 24-year-old crowd. And again, because a lot of up to 75% of women, especially, are asymptomatic, that is the reason why we would offer asymptomatic screening for folks. When we talk about treatment, so we treat with a week's worth of doxycycline twice a day, 100 milligrams. And it's really important to remember to offer partner treatment. Chlamydia is one of these infections that falls under the guise of expedited partner therapy. So if you live in a state where that is legal, then we highly, highly recommend doing that, because reinfection from a partner can be very common. So making sure that both the patient and their partner are treated before they resume having sex is super important to prevent reinfections. Why should we screen, or why should we care about asymptomatic disease? Well, untreated chlamydia can have very serious results, consequences for women's health, including pelvic inflammatory disease. So that's upper genital tract infection. You can have inflammation and infection of the fallopian tubes, the uterus. That can result in infertility. It can put people at risk for ectopic pregnancy. So it's a very serious, thing we don't want to miss. And then just as a quick side note, when we, look at diagnosing PID, we should have a very low clinical threshold to make that diagnosis, because we don't want to miss cases of PID for those reasons. I'll also just mention it is a reportable infection, which is a good thing, because we want to be able to keep track, epidemiologically, of how we're doing with treating these types of infections. For other infections like trichomonas, where they're not reportable, we make our best guesses, but otherwise it's kind of a shot in the dark.
Yeah.
And I guess the only other point I was going to make here is that some cases of chlamydia may clear spontaneously, but for the most part, we don't want to rely on that, and we want to make sure that people are, getting an accurate diagnosis with a NAT test and being treated appropriately.
Yeah, those were all such good points. And again, I mean, I think the take home with chlamydia is studies have shown over 70% of people who have chlamydia have no symptoms. So this really is a silent way to have disease that can lead to really serious long-term impact, especially for fertility concerns or upper genital tract infections in females.
Yeah.
I'm going to talk a little bit about gonorrhea. We were doing really good for a while controlling gonorrhea, but it has a big upsurge recently. And one of the biggest challenges with gonorrhea is the antimicrobial resistance. This is a very smart microorganism. It is able to change pretty readily. And when it gets a lot of antibiotic pressure, it can develop a resistance to that antibiotic. And so now we really are stressing, instead of oral treatment, to use a shot and to use ceftriaxone 500 milligrams. And the reason that that is so important is because that dose of ceftriaxone will also clear oropharyngeal gonorrhea. And it's found that oropharyngeal gonorrhea is actually where a lot of the resistance develops, and that there's mixing of the bacteria genetic codes in the throat. And so it's really important that when we find gonorrhea, for instance, in the cervix with a test or in the urine, we still give a dose big enough to clear the throat of gonorrhea, even if we don't test that. Now, I do agree with what Anna said about chlamydia. Testing multiple sites for gonorrhea is also important. And all of those sites can be treated with this 500 milligrams of ceftriaxone, except for ocular gonorrhea, and that's a gram. So I feel like, again, you can consult CDC guidance for that. The most common thing we see would be treatment with 500 milligrams. We still have a ceftriaxone shot. We still have some cephalosporins that can be used, but we're not trying to use those first line because, again, if we get more resistance developing, we may be losing the ability to treat gonorrhea except with an IV at some point. And so clearly we don't want to move into that. All of the same things Anna talked about with potential perinatal transmission are true, potential upper genital tract disease are true. And so screening routinely for gonorrhea is also something that is very important, and to have a low threshold for screening. And then also to remember the partner needs treatment. This is a little more tricky because of the idea that you hope that the partner can get tested and then also get an IM injection. I don't know, what do you usually do in your clinic for expedited treatment for gonorrhea? Do you offer it, Anna?
Oh, I want to say I think we could either do the oral cefixime dose, or you can send them to the health department. If,
Yeah.
if they have their own provider, they can also go see that person.
That's what we're doing as well, because expedited treatment has definitely been shown to be helpful to prevent recurrence. But again, the first line for gonorrhea now is an injection. And so if it's possible, you want to be using that. Another disease that's making a huge comeback is
Oh, actually, I have a quick question for you.
yeah.
What should people do if they have a penicillin allergy and they're diagnosed with gonorrhea?
Yeah, I think one thing to do is try to get penicillin testing and make sure it's a real allergy, because we know that most people who are thought to be penicillin allergic are not. And the second is you can use a cephalosporin treatment, usually under observation. So those would be the top two things I would recommend. How about you?
Yeah, just teasing out what their allergy is and how
Yeah.
serious we think it is, and then same.
Yeah. Yeah. And, if you really are not sure they have an allergy, sometimes getting people allergy testing is a really good gift to them, because then they
Yes.
won't go through the rest of their life thinking they're penicillin allergic.
Yeah, it's kind of a big deal if you think about it,
It
right?
is.
Like
It is. Wipes
anytime
out a
you're in
lot.
the hospital, I'm
Yeah.
like, oh no, penicillin allergy, that really complicates pretty much everything.
Yeah. Yeah. Well, what about syphilis? Talk to us about that.
Okay, yes. So syphilis is another bacterial STI that's caused by a bacteria called Treponema pallidum. I had the pleasure of, as a third year resident, rotating through UCSF as for my away rotation, and I got to see dark field microscopy in use at the STI at the city clinic, which is a STI clinic basically. It was very exciting. I think my understanding is that those are very rare nowadays, so lucky me. But syphilis is a difficult infection to treat. We've seen a resurgence, unfortunately, in pregnant women, and especially so cases of congenital syphilis have been rising quite un, in ways that we don't like to see. So currently pregnant women are, now it's, I think, as we were just saying, there's a state mandate to test twice in pregnancy, especially at the time of delivery. And so syphilis can present and can be present in over many, many, many years. There's an early phase with that has some symptoms, and then the symptoms go away, and then there's a later phase. So it can kind of pop up, and then if it's not on your radar, then it's easy to miss probably. And then in terms of testing for it, so this has probably been for the last, gosh, like 10 years almost, that the sequence of the tests has slightly changed, but just know that one, primarily it was done out of cost savings, and two, it has made it a little bit easier to diagnose late latent infections. So in terms of how to interpret the results, I always refer back to the CDC guidelines or to the ACOG, the American Congress of Obstetricians Gynecologists site for more information about that, because sometimes it's difficult to remember, how to treat. Early cases, you just get the one dose of the benzathine penicillin versus late it's 3 doses, and you have to give them within a certain time frame. I think it's 9 days. Otherwise, you have to start the series over. So there's a bit of nuance to that.
Yeah, and I do think too, like we're living in an age where, we know that the CDC treatment guidelines were taken down and now they're back up. And I just want to say that for those of us providing direct patient care to individuals and wanting to know the latest guidance, of course, we, are happy the CDC guidelines are back up, but there's also backup methods. The American College of OBGYN actually is posting all of the treatment guidelines. So we'll include some sites at the end of this talk that you can use to get accurate information, because I think we all realize that finding timely, accurate information is really important for the type of care that we can offer to our patients. So why don't we talk about the latest New England Journal article and the new kid on the block? Anna, why don't you take us through bacterial vaginosis?
Okay. So BV, for those who don't know, is basically a abnormal alteration of the vaginal microbiome that's characterized by a fishy odor. You've got clue cells, which are bacterial studded epithelial cells that are visible on microscopy. There's an elevated pH, and then the pathognomonic grayish discharge. BV is a condition that affects up to a third of women worldwide, so it's extremely common. It also has a lot of health repercussions, so it's kind of the unappreciated, underdog, I'll say, of the STI world now. But we know it's associated with PID and surgical site infections and preterm labor, so all sorts of things. So the New England Journal article that came out was from an Australian group, from Catriona Bradshaw's group, and basically they looked at a specific male partner treatment regimen for folks with an incident BV infection. And there was a significant reduction in, I think it was actually about half, like 50% reduction in the number of recurrent BV episodes by 12 weeks after the initial infection. So, to put this into a little bit of context, historically, there have been quite a few male partner treatment studies, but in the past, maybe it's just been the one dose, or it just like there's been a lot of mixed data. So this is probably I think, to the best of my knowledge, this is the first study that's really shown like a dramatic improvement, even though the recurrence rates at 12 weeks were still quite high for the treatment group, like 30%, right? Which we know is pretty common with BV. So we haven't cured BV completely yet, but we've definitely made some inroads here. And so, this and another study that was done in Kenya by Mehta et al., which looked at the penile microbiome, so the bacteria that live on, the penis around the coronal sulcus, actually are strongly associated with new BV symptoms in female partners, which again really highlights this idea that it is a sexually transmitted infection. Now, there's a lot of nuance to this, and of course, like, you can get BV after just antibiotic exposure, but women may get it, most likely at the time of their menstrual cycle and things like that. But certainly, we should not discount the importance of talking about partner treatment. And so the regimen that they used was topical clindamycin and oral metronidazole for a week. And with with minimal side effects for the male partner, which I had some concerns about them, completing and being adherent to, but so far so good. So I think there's still a lot of, questions that, folks in the field are thinking about, like what do we do beyond the 12 weeks, and who does this need to be offered to? But I think my personal takeaway from this was offer male partner treatment to potentially everybody with BV, not just those with recurrent BV, although it's probably highest yield for women who have recurrent episodes.
And the treatment is 7 days of metronidazole, 500 milligrams twice a day, plus clindamycin 2% cream
Yes.
on the penis and the coronal area. And, there has been some concern about will males take treatment if they don't have symptoms. But I
They
have
don't
to
have
say that,
symptoms.
I've had definitely some partners take treatment because this can be recurrent and really, really hard to treat. And they, of note, they stopped the trial early. Like the Data Safety Monitoring Board said, you got to stop the trial. We're seeing way too
Yes,
big of a difference.
right.
And so they stopped the trial early because of
Mhm.
the difference that they were seeing. So I think it's pretty exciting for those of us who've been in the vaginitis world for a long time to finally have these results coming out.
Yes, because importantly, like there aren't a lot of new treatments for
Yeah.
BV. We're going back, we're kind of digging into the archives with boric acid and other things and trying new combinations. But I guess what was the last new thing that came out? Signitisol, tinidazole,
Yeah.
right?
Right.
Like there's
Right.
not a lot of new stuff being developed. So
Yeah, they were just
from
cousins to metronidazole, right?
yeah, exactly. So from our mouths to to VC funding ears to fund, women's health startups that want to develop new drugs for BV, we're
Yeah,
here for it.
yeah. Well, let's move on to viral infections. And I think one of the differences in viral STIs is they tend to not be curable. There's a few exceptions, but especially human papillomavirus and HPV or herpes simplex virus and HSV. And these viral infections are actually more common than bacterial infections. In fact, HPV, 80% of adults will have an HPV strain at some point in their lives. The good news is that our body gets rid of it most of the time, over 90% of the time. And the good news is that most HPV doesn't cause symptoms. There are types that can lead to genital warts, type 6 and 11. And there are what's called the oncogenic types, or the types that can lead to changes on the surfaces of the cells of the cervix or the vulva and vagina that can lead to precancer and eventually cancer. And so HPV is incredibly common. And then HSV also, it's estimated that in the United States, 25% of adults have HSV antibodies in their blood. And most people had no idea that they have it when they did a serological study. And so we don't really offer screening for HPV except in the context of cervical cancer screening. And unfortunately, we don't really have any screening test for males yet that's been reliably shown to be a really good way to screen for males. But we know that for HPV, we have a vaccine. We have a great vaccine. And if it's given early before there's any exposure to HPV, and remember that exposure is most commonly by penetrative intercourse, but it doesn't have to be. It can be digital touching. So if that vaccine is given before penetration, it can lead to prevention of over 90% of cervical cancer. And I also just want to point out that throat cancer is increasing in males. And actually, throat cancer is killing more males in the United States right now than cervical cancer is killing females. And that's because we don't have a pap smear equivalent for the throat. And 70% of throat cancer is caused by HPV 16. So males are impacted greatly by HPV cancers. And that's one of the reasons in this country that we are fortunate we have a policy of vaccinating both males and females. And I think that when we think about how to prevent HPV, the vaccine is a superpower. There's been a lot of work done on a herpes vaccine. There's been many, many trials. Unfortunately, we don't have a reliable herpes vaccine at this time that we can offer to our patients. But we do have other ways we think about preventing herpes. Anna, do you want to talk about that?
Yeah, so in terms of prevention, like if you are somebody that has had an exposure to type 1 or type 2, and don't want to pass it on to a partner, using chemoprophylaxis, medication, antiviral medicine, acyclovir or valacyclovir is a good way to make sure you're not having new outbreaks that would put a partner at risk. Um, it's very common, and there's probably I don't know that there's any way to avoid it except for being completely abstinent. Um, but once it is possible to be exposed to both type 1 and type 2, most folks with the first exposure may have some sort of viral prodrome. So there may be some symptoms the first time around, and then subsequently may not have outbreaks or may not have infections. But for folks that have 3 or more symptomatic outbreaks in a year, um, being on a suppressive maintenance dose of antiviral medications can also help prevent future outbreaks.
Let's talk too about, I think there's still confusion about herpes type 1 and type 2. Classically, we're taught that herpes type 1 is oral, herpes type 2 is genital. But I think it's really important to note that the most common new herpes genital infection in individuals under the age of 30 is type 1. And
Yeah.
that's because of oral sex.
Yes.
And so I feel like herpes type 1, type 2 distinguishing is a little gray sometimes
Yes.
as to what is causing genital tract symptoms. But independent of whether it's type 1 or type 2, like you mentioned, you can take medicine to try to decrease recurrences. And I find that when people talk to their partners about herpes, sometimes it's helpful to suggest the partner actually get tested for serology, because most people who have herpes don't know they have herpes, especially type 2.
Mhm.
And so if you end up with a partner and you both have it, you don't have to worry so much about transmitting it to each other. It can make it a little easier to communicate about it. And so it is a test, though, where you want to make sure that you're getting the right blood test for it, because there's some blood tests that don't work as well as others. So I definitely would look that up, and also
Meaning you get the
your
IgG, not the IgM.
right,
But
right,
that
and
also doesn't tell you when your exposure may have happened.
right.
It just says that you've had an exposure at some point. And so there's no, unfortunately, I wish we had a crystal ball to be able to tell folks like when the exposure happened, which partner may have been responsible, but we can't tell you that with this blood work. All we can say is whether you have it now or have had an exposure before.
And I should bring up, that's actually really similar to HPV as
Yes.
well. When you
Yes,
get an
exactly.
HPV test that's positive, you don't really know when you acquired that HPV. You don't know which partner it might be. You don't know how long you might have had it.
Yeah.
You can have it in your body and it can be not replicating. And if it's not replicating, then you won't detect it with a test, but then it can start replicating and then you'll detect it. So it's very hard. And that is one of the things I think that's really hard for patients to handle, is you can't really tell them when they acquired these viral STIs, but they're
Potentially if
so common.
somebody's had serial tests in a short time frame, maybe, but even then it's probably hard to say
And
for
then
sure.
it's really tricky. Yeah. Well, so let's talk about HIV and AIDS. So Anna, what do you tell your patients about testing and about prevention?
Yeah, that's a great point. So it's still a thing, contrary to I think popular belief nowadays. And while cisgender women don't make up the majority of new infections for HIV, cisgender Black women are disproportionately affected. So, that is definitely a patient population that I especially stress talking about HIV awareness to. But I would if you're not sure, just talk to everybody about it because it certainly can affect everybody. In terms of prevention for women, there are a couple strategies out, and this is called pre-exposure prophylaxis. Um, if you have a partner who is living with HIV, then using a strategy called treatment as prevention is also totally acceptable. And that means that the partner who's living with HIV has a suppressed viral load for at least I want to say 6 months. And basically that puts them at an extremely low risk for transmitting. So we say undetectable equals untransmissible in that setting. Now, for folks that don't know their partner status, who may live in a high prevalence area like the DMV, like where I am, there's a higher likelihood that you may be exposed to HIV, and so I think it's totally reasonable to talk to patients about pre-exposure prophylaxis. Now, for women, there's an oral option with Truvada, and also which is a HIV, one of the medications that's used to treat HIV, but it has to be taken daily, and it takes about 3 weeks to get an appropriate level in vaginal tissue to be protective. There's a new injectable option with cabotegravir that is given. It's basically monthly dosing, so it requires a little bit more frequent follow-up. But those are some newer options. There was also a really exciting recent trial of lenacapavir, which is another injectable, but that's only given every 6 months. And that was shown to be also extremely effective at preventing new HIV incident infections. It's not available for clinical use yet, but hopefully coming down the pipeline soon. As you can imagine, with oral PrEP, a lot of women just don't take it long enough. And so the efficacy rates just aren't as good as they are in men who have sex with men, or transgender women. So counseling patients about potential side effects, how long most people use it, what to expect from it, I think is totally reasonable. But these are all tools available in our toolkit to keeping people safe from acquiring HIV.
And I think it's important to remember we're talking about STIs. Whenever you diagnose a new STI, those put you at increased risk for acquiring HIV.
Yes.
Especially the ones that cause a break in the mucosa, for instance, herpes. And so I think that whenever you're doing STI counseling and treatment, including HIV counseling and also testing, is helpful. And I would mention in pregnancy now, we definitely recommend testing all pregnant individuals just as an opt-out, just as a matter of fact, for HIV, because again, we really want to find it and treat it so we don't end up with perinatal transmission of HIV. And so that's a national guideline as well, to test for HIV in pregnancy. And I think it's recommended now, isn't it, that all adults should have an HIV test at some point in their lives?
Yes, at least once.
At least once, yeah. The other thing that we should talk about with viruses is the hepatitis viruses, hepatitis B and C. Hepatitis B, fortunately, in this country, almost everybody has been immunized against hepatitis B, so we don't have near the risk that we used to have with needle sharing or with sexual transmission of hepatitis B, as it can be transmitted in those ways. And again, in pregnancy, people do get routine screening for hepatitis B to make sure that they have protection against it. Hepatitis C, it's newer recommendation for all pregnant individuals to be screened for hepatitis C. And we don't have a vaccine against hepatitis C yet, but we actually have really good treatment now. And so that can really prevent liver cancer from happening. So I think it's really helpful to screen for hepatitis B and C, to talk about it with your clients, because we can do something about it and we can prevent more serious sequelae from happening. Now, let's see. What about, I guess we should talk about trichomonas.
Can we pause for just a second? I lost my notes page. Yes, so trichomonas is one of the, it's probably the most common STI but it's not reportable, unfortunately.
Most
Um,
common bacterial or parasite, right? I
Most
mean,
common parasitic
yeah,
infection.
HPV
Yes.
is a lot more common.
That's true. That's true.
Yeah.
So in terms of, so again, population that's affected, certainly the younger crowd we mentioned, 15 to 24, but also older women tend to be affected as well. So we want to make sure we're keeping this in mind. Trichomonas.
Older. Can you talk
Older.
about older? I'm a
Sorry.
little sensitive to that word older.
I didn't say old. I didn't say old. I said old. I also put myself in the older crowd.
Really, we're talking like up to 40-ish, you know.
Yes, yes, exactly. So I guess the big thing with trichomonas is that not too long ago, the treatment duration changed. So previously, we were just doing a single hefty oral dose of metronidazole for people without HIV with vaginal exposures compared to women living with HIV. We're getting twice daily dosing for a week. And now the twice daily dosing for a week is actually recommended for everybody because it was associated with higher clearance rates. We, just as an aside, we screen women living with HIV for trichomonas in our routine annual GYN visits because again, it can stay dormant for many years. And so in terms of like when you have this diagnosis of trichomonas to, bring it up to a partner, we were saying yesterday that this shouldn't be a relationship wrecker necessarily because of the fact that it can stay dormant for many years. And you had an interesting anecdote of a patient.
Yeah, I mean, Trichomonas lives in the glands that are right up by the urethra, and it can hang out there for a really, really long time. And I actually had a patient who was a nun who came in through many different providers for yellow vaginal discharge. And finally, I tested her for trichomoniasis, and it was positive, and she cleared her discharge with treatment. She'd been in the nunnery for 18 years, and she was pretty clear she'd been celibate that time. So I think that was my example of, gosh, you have to be really careful when you tell people they have trichomoniasis that you don't know how long they've had it or where they got it from. Their partners clearly need treatment because just like gonorrhea, chlamydia, syphilis, they give it back and forth to each other. But I think that you have to tread a little lightly when you're telling people that their partners need treatment for trichomoniasis.
Yes, exactly. But to that note, if somebody remains positive when you bring them back for the test of reinfection, and you've ruled out that, their partner was treated or that they, were completely adherent to therapy, um, there's also a whole algorithm that our wonderful colleagues at CDC have put together in terms of treatment escalation. Because very, very rarely, maybe like 4 to 10% of the time, I want to say there's evidence of metronidazole resistance in trichomonas treatment. So in those cases, one would escalate dosing and then potentially send a sample to CDC for culture to double check that.
So, Anna, for any of these STIs we've been talking about, do you change your dosing based on the body weight of the individual?
No, I don't think so.
Yeah, I don't either. So I don't think we really have to think about obesity as a factor that leads to a change in the treatment as far as STIs for that we've been
Right.
discussing.
Yeah, that's a
But
good.
I think that's also a common clinical scenario. So I just wanted to address that.
Yeah.
Um, so I think one of the things that, we've been talking about testing, let's talk a
Mhm.
little bit about symptoms. Now, the thing about STIs, as we mentioned, many of them have no symptoms,
Mhm.
but the symptoms that can go with STIs actually can go with a lot of things. And so, unusual discharge, pain during urination, sores, itching, little irritation around the urethra, there can be a lot of different symptoms associated with STIs. And so I think remaining suspicious is really important because, at least most of the patients I see when they come in, they think they have yeast. They always think they have yeast. And truthfully, there's been studies done that have shown maybe 30% of the time they have yeast. And the
Mhm.
rest of the time they might have an STI or another vaginal infection like abnormality like bacterial vaginosis or a bladder infection. And so I think it's really important that when you see these non-specific symptoms that are very common, that you
Mhm.
don't just jump to yeast, you don't just jump to
Or yeah.
over-the-phone treatment. You
Yeah,
say, we really need to evaluate these because there's a lot of different things that these can be. Now, I would say people who get recurrent bladder infections, there has been studies shown that they are good at knowing they have recurrent bladder infections and you can treat them. And, we're not dealing with those algorithms today. People who have recurrent BV and recurrent yeast that's been culture shown and been, treated time and time also can be good at their symptoms. But for people who have acute symptoms, you don't quite know what's going on. I think an evaluation, even though I hate to say it because I know it can be inconvenient, but I think a patient gets better treatment if they have an accurate diagnosis.
for sure. And
And
oh, I was just going to say, so should we, or is it okay for the provider to just call in antibiotics over the phone?
I only time I do that is for recurrent UTIs where I'm really sure, feel very clear, and then the patient will come if they don't get better and get a
Mhm.
culture. I do not do it for vaginal symptoms, even though they really, really, really want you to.
Yeah.
Yeah. Yeah. So why don't you talk to us about the ideas of testing or diagnostic options that we do have? Because we do want to be as flexible as we can be with our patients.
Yes, exactly. So, I mean, historically, we've used a lot of culture-based methods. We talked about microscopy for vaginitis. I think the reality in practice, like we mentioned earlier, is that people just don't have microscopes in the office. And so nucleic acid amplification-based testing is really kind of the wave of the future and already being used pretty extensively. So but I do think we can be flexible with patients and have them come in and self-collect a swab or leave a urine sample. And, while cervical or vaginal samples may be slightly more accurate, you can still make a diagnosis from a urine sample. So, it doesn't require a pelvic exam every single time. Although sometimes it's useful if you're, worried about other things. Um, but so self-collecting vaginal swab is fine. Um, Urine testing we know is also accurate by NAT, and then some tests of course require blood samples being drawn, syphilis, HIV, etc. um, but for the most part I think if you have a workflow for it where a patient doesn't necessarily have to see a provider to leave a sample, you can be a little bit more flexible in terms of asking them to come in during their busy workday.
And I think the other thing is, home testing. There
Yes.
are a lot of times you can go online and get home nucleic acid testing ordered. I would say it can be costly. It can be $80 to $100 to get STI screens that way. But it is possible and it might be the best option for some people. So it's important to know that those are out there as well. You and I both see a lot of yeast infections because we do a vaginitis clinic, and there is fungal cultures for yeast are really helpful. Bacterial cultures in the vagina are not helpful because you
Oh,
get,
if you're looking for group A strep.
yes, they get all kinds of things growing in them, like E. coli and Prevotella, and then you think, what in the world is going
Yes.
on? So I really, really don't usually do a bacterial culture of the vagina. I sometimes do a fungal culture.
Yeah.
But
Thank you for this important PSA.
yeah, and then the other thing I would just say in pregnancy, if you do have a yeast infection in pregnancy, again, we're not thinking of yeast as an STI, but just because we're talking to providers about common things.
Mhm.
It isn't recommended to use oral fluconazole in pregnancy, even though, again, patients might want it, but it's recommended to use vaginal treatment. And you often have to treat longer because in the vagina, the pregnant vagina has a higher estrogen level and a higher glycogen level. and which is wonderful substrate for yeast. So it's often necessary to use more treatment in pregnancy, in contrast to the other STIs we've been talking about, where treatment in pregnancy, you can't use doxycycline, obviously, but you use antimicrobials in pregnancy, and you don't change your dose just because they're pregnant. Yeah. Well, why don't we talk about prevention a little bit, so that we can keep people from getting these STIs? Um, are all condoms created equal? What would you tell a patient?
That's an excellent question. So we know that so latex condoms are great for preventing HIV and bacterial STIs. They are generally, considered less secure for the viral STIs that we mentioned, because there's still other skin-to-skin contact that happens. But to answer your question, not all condoms are created equally. There are, synthetic, or we could say quote unquote natural membrane condoms that, so lambskin or other materials that will still have larger porous membranes that allow viral particles to pass through. So ideally, unless you're severely latex allergic, latex condoms are the way to go for STI prevention.
And there is also synthetic condoms that are not membrane condoms that can offer good protection and are not as sensitive to the use of lubricants.
Yes.
Sometimes latex condoms will break down with lubricants.
Sure.
And so, but I think it's also important, we're in an age right now where people are like looking for quote natural. And if you buy a condom that's quote natural because it's made from a membrane or a skin, you're not going to get as good a protection. So this is a case where you don't really want to just look for natural on your label and assume that it's good. And dental dams are also an option. They are not quite as common, not used as commonly. We mentioned vaccinations already as prevention. Hepatitis B vaccination, which is given in infancy commonly now, and HPV, which can be started at age 19 and go up to 45. And I think one of the most important things is to have regular testing and communication with partners. And, this can be hard, but I think it's very important to be communicating with your partners in a way so they understand what it's going on with your own body and you understand what's going on with their body, and to make decisions about protection, for instance, about herpes, like we talked about, and so forth. So that's another big component of this. And when we are talking again to our patients, we mentioned this early on, but we need to be really clear that we're trying to use messaging that doesn't assume a gender, or doesn't assume who their partner is, or doesn't even assume what type of penetration is being used, but to really try to make our conversations as neutral as possible, and put patients at ease considering our language. It is true that reducing the number of sexual partners can reduce exposure. And that's true. And so how can you say that to your clients in a way that doesn't seem off-putting? Sometimes if you just say, how many sexual partners have you had in the last 3 months? It can, be sure how are you asking that? What's your tone of voice? And try to get accurate information without introducing the idea of stigma. Are there other things that you think about? Other behaviors or so forth that you think about, Anna, when you're taking history or you're talking to your patients about harm reduction?
Yeah, and I think you can also just phrase it in terms of, I'm asking about this because XYZ, like these are behaviors that put people at higher risk, so that they're not feeling targeted by your questioning necessarily, but potentially other high risk behaviors might be exchanging sex for money or food or drugs or whatever. Heavy, alcohol use or recreational drug use at the time of intercourse, or recreational drug use with needle sharing. So those would be things we would want to ask about, again, in a as non-judgmental way as possible to make sure patients are feeling comfortable answering those.
Yeah. And I think you already mentioned HIV prep, and that could be another harm reduction technique that I think data shows we really aren't talking about that with our patients,
We're
right?
really terrible at talking about it, it turns out, especially OBGYN. So
Yeah.
this is an ongoing area of research that I know of that quite a few people are looking into. But separately, there was a study that said, or that showed that providers talking about PrEP makes it more likely for people to consider using it. So it does work. I think some of the discrepancies are that providers don't feel comfortable talking about PrEP, or, we're already so busy with the annual visit that it's like one more thing that we have to know about and talk about. But it is really important, and it makes an impact.
Yeah.
The other harm reduction option that I forgot to mention earlier in our chat was doxy pep. We come back to that now. So we talked about a little bit earlier about using post-exposure prophylaxis for gonorrhea, chlamydia, and syphilis using doxycycline. So there's been now 3 large randomized controlled trials that have shown a significant reduction in these STIs for men who have sex with men and transgender men. There was, I believe, one trial with cisgender women. This was done in Kenya. It was an open label trial. And it was underwhelming because the patients probably didn't take it. They looked at hair levels of doxycycline and they were really low, under 30%. So I feel like this is like another story, just like with PrEP, that the options for women are not, I don't know, there might be some biological differences in the way the doxycycline is, absorbed or what have you, but we need the same options that are available to other populations for women, because women are also affected by these things. So just my 2 cents on that.
Yeah. And, as we've talked a lot here, as we're wrapping up, I want to say that living with a chronic STI, especially when we think about herpes, HIV, HPV, this can be really difficult. And I do want to offer empathy to patients as they learn how to message to their partners and learn how to talk about it. I certainly have a lot when I tell people they screen positive for HPV on their pap smear. One of the most common questions is, what am I going to tell my partner? And so we're going to put support resources at the end of this. The American Society Sexual Health Association has really good information on how to tell your partners that you have herpes or HIV. Planned Parenthood has good information. American College of OBGYN has information. And so I think that I want to encourage us to realize that when we tell people they have a chronic STI, that they're going to be able to give it to their partners, that there is a burden that they carry. And that is one of the reasons that people don't want to get tested, is because they don't want to have to carry that burden. So I think that we can try to offer them the best support we can. And again, we'll put resources so that we can really encourage safe practices and regular testing and keep our patients healthy. And try to work toward curbing the current epidemic we have of syphilis, of gonorrhea, of STIs increasing markedly in this country right now.
Absolutely. And just knowing that if you yourself are affected by, like a gonorrhea or chlamydia, that doesn't, make you a bad person or a dirty person. Like, these things happen, they're common, they're treatable. So we're again, our conversation today is hopefully aimed towards destigmatizing sexually transmitted infections, and passing on to patients that it's okay, and that they'll get through it, even though it's can be traumatizing at the time.
Yeah. All right. Well, thank you very much.
Thank
Really,
you.
yeah.